Hey guys, this is Dr. Hub. In case you haven't subscribed, please do subscribe for updates.
So what is splenic trauma? So here in splenic trauma, the spleen, we need to know it is the most commonly injured organ in case of the blunt thoraco-abdominal trauma. So it is a MC, that is the most common organ, injured organ. Then is the hilar injury, which is present with the rapid development. So there is also presence of the hilar injury. It presents with a rapid development. So there is a rapid development of the shock and deteriorates fast. So rapid development of the shock is seen, and there is a fast deterioration. In other types, the features of shock, tenderness and abdominal rigidity in the upper left quadrant is seen. So in case of other types, the features of shock are seen, the shock and the abdominal rigidity. So they are seen in the left abdominal upper quadrant. Next is, what is the Kerr sign? We need to know the Kerr sign. The Kerr sign is referred to the pain in the tip of the left shoulder. So tip of left shoulder, you have a pain. So that is, we have the phrenic nerve by the fibers. So phrenic nerve, the fibers we need to know is C5 and C5. So this is due to the irritation of the undersurface of the diaphragm with blood. So irritation. So what is this irritation brought by? Irritation is brought by the undersurface. So there is an undersurface of the diaphragm, with the blood. This causes irritation. Next is the balance sign. So what is known as balance sign? Balance sign, this is the sign which indicates a fixed area of the percussible dullness. So this is a sign which indicates the fixed areas. So it indicates a fixed area of the percussible dullness, and this is present in the left upper quadrant due to the coagulation of the blood. So it is present in the left upper quadrant due to the coagulation of blood. Then we move on to the AAST. This is important, AAST grading for the splenic trauma, that is the American Association of the Surgery of Trauma. So this includes the grade 1, 2, 3, 4, 5. So let's look at grade 1. The grade 1 is the hematoma. The hematoma, it includes a subcapsular hematoma. So the hematoma, it includes a subcapsular hematoma. It involves less than 10% of the surface area. So it involves less than 10% of surface area. And what about the laceration? The laceration is, there is a capsular tear which is less than 1 centimeter in depth. There is a capsular tear less than 1 centimeter. So hematoma, there is a subscapular hematoma involving less than 10% of the surface area. Laceration, capsular tear less than 1 centimeter in depth. So what about grade 2? Grade 2, there is a hematoma. What do you mean by hematoma? There is a subscapular hematoma. It involves about 10 to 15%. So there is involvement of the 10 to 15% of the surface area. And laceration, if you talk about laceration, it amounts to about 1 to 3% in depth. Next we move on to the grade 3. The grade 3, it includes a hematoma, that is a subcapsular hematoma. So this involves more than 50%. So involving more than 50% of the surface area, and in also or in trabecular vessels. Then is the laceration. So in grade 2, when we saw, the laceration was 1 to 3, and in grade 1 it was less than 1. So in grade 3 it is going to be greater than 3, more than 3. So grade 3 is for laceration being more than 3, and 3 the unit being centimeters in depth or involving the trabecular vessels. Next is the grade 4. The grade 4 has a more than 25 devascularization, more than 25% devascularization, and the laceration, it involves only the hilar vessels. Then we move on to the grade 5. So grade 5 is a completely shattered spleen. So completely shattered spleen, and there is a complete devascularization. Now let's look into the splenic trauma. So how do you manage? So in case the algorithm, so in case when you have a splenic trauma, what is the thing? So you can have an unstable patient as well as you can have presence of a stable patient. So in case of an unstable patient, you do the FAST. So in case the FAST, it turns out to be positive, you do the exploration laparotomy. And in case the stable, in case the patient is stable. On the other hand, if it's stable, you do a FAST, and then you look for the observation. And after the FAST, you also look for the CECT, and you classify them as per the grading we discussed, that is grade 1 to 3 as well as a 4 or 5. So in case of grade 1 and 2, what is the thing you do? So in case of grade 1 and 2, what you can do is there is an observation as well as you repeat a scan after 72 hours. So another one, what we do is, along with grade 3, the next alternative route would be the pseudo aneurysm. So you look for the pseudo aneurysm, and then there is also the contrast blush and the moderate bleed. So after this, you go for the angioembolization, and this is leading to, in case of it's unstable, in case it is unstable, in case there is peritonitis, or in case it is not available. So then you move on to the exploration laparotomy or the splenectomy. So exploration laparotomy or the splenotomy. So exploration laparotomy and splenotomy, it is done directly in case of the grade 4 as well as the grade 5.
To learn and grow daily like this, please do subscribe.